Hi everyone, it's great to be joined tonight by Dr. Ferguson. When we advertised this Ask the Expert session, somebody on our Facebook page said Dr. Ferguson was one of the best, and we couldn't say it better ourselves. Dr. Ferguson is a transplant hepatologist at the Queen Elizabeth Hospital in Birmingham, and today's session is about liver transplantation for those with PSC. Dr. Ferguson has a presentation. He's going to talk us through some slides, and then there'll be plenty of time for questions, and Dr. Ferguson can take those questions at the end of the presentation. Please keep your questions, I always say this, but please keep them as brief as you can, and just bear in mind that Dr. Ferguson cannot give individual medical advice. Dr. Ferguson has sent his children and his wife upstairs so he can join us tonight. So we are extremely grateful for your time, Dr. Ferguson. And if you'd like to start your presentation, that would be fantastic. Thank you.
Well, thank you. Really nice to see you all. This is an actual festive scene behind me, not a fake one. This is my house. It's nice to see you all on a December evening. Paula and the team asked if I could just prepare a few slides, so I'm just going to share my screen now. And if you hear the sound of rhino, that's my two boys running around upstairs. Okay, so this talk is just really a few slides and just give you a feel for what I guess I think about when I've got a patient with PSC. Firstly, when we're thinking about whether transplantation is the right thing to do, then about how we might manage a patient after transplantation and what complications might pop up within the clinical service. I'm a physician, I'm not a surgeon, so I'm not going to talk about the operation. I'm not an anaesthetist, I'm not going to talk about putting someone to sleep, but I'm going to talk about the physician's perspective. So firstly, this is slightly historical now, but has actually changed a bit. But I think what's interesting about this is registrations for patients on the national waiting list. Now, PSC is a very rare condition, and yet, in fact, I think it's become now the third highest reason that people are registered on the waiting list in the United Kingdom. So despite it being a rare condition, there's a significant number of people awaiting transplantation in the UK for PSC. And this is work done by some of my colleagues a few years ago. And this is lots of funny lines and lots of like triangles. But basically what it's demonstrating in the UK is that less patients are being listed for autoimmune hepatitis, probably because we're getting better at treating those patients over time. There's a slight increase in PBC, but I'd expect that to dip off as we've got new therapies. There's a gradually sustained increase of people being listed with PSC over time. Now, why that is? Maybe we're getting better at diagnosis, maybe there's more inflammatory bowel disease, but we are listing and transplanting more people with PSC. And certainly in Birmingham, the PSC service is one of the absolute key services involved in transplantation. So this is a made-up patient, not a real patient, but just kind of fairly typical of someone who might come to the clinic. We'll call him Paul. So Paul's 24. He's a male, so a young male. So it's often the way PSC, not exclusively, of course. Has a long history of a colitis affecting all his colon, and was diagnosed with colitis 10 years. So he's already lived with colitis for a long time. Had presented with PSC again a couple of years ago, and these are the kind of key investigations. So he has a raised fibroscan. For those who don't know, that's an indicator of how much scarring there is and that's a high value, 38 kilopascals, indicates cirrhosis or a very scarred liver. There's no dominant stricture, so no main biliary stricture going on, but Paul is jaundiced with a bilirubin 50. You can generally see if someone's jaundiced if their bilirubin pops over 40. INR, that's how their blood clots is out a little bit. albumin, the amount of protein they're making from their liver, has dropped down a bit. So Paul's liver is not working that well and is scarred. The spleen has got bigger. Now, the spleen gets bigger when you've got a very scarred liver. There's no fluid in the tummy, so no ascites. And Paul's also got varices. Okay, so sometimes the question can be, should we list or not list Paul for transplantation? Now, I guess what's different about PSC to some other conditions is we do think about listing a bit earlier because it's unpredictable. And what would worry me about someone like Paul is he's jaundiced, he's got cirrhosis, he's got splenomegaly. It's about what might happen next. And certainly a patient like this, we certainly would be thinking definitely about assessing them and potentially listing them over the next while. And the reasons we tend to think about listing people with PSC, that's liver failure. So if there's signs that someone's liver's failing, if you're getting repeat biliary infections, so repeat cholangitis, and on rare occasions, just the itch is so bad we can't manage it medically, and we list someone for that reason. They're the kind of usual indications in PSC. Now, Paul has his transplant. So there's lots of options that might happen during transplantation. I brought some of these up. So you may or may not be aware about the type of donation. So there's something called DCD and something called DBD. And that means donation after brain death or donation after cardiac death. And any of you who might be going through the transplant process, or maybe in the future, will have this explained to you. But it is important because if someone dies and they're found to be brain dead, the retrieval organs is done in a much more controlled manner than donation after cardiac death. And it's been an area of some controversy whether we should use these types of organs in people with PSC, but we've certainly published that it's safe to do so, but I bring that up. Then there's often a question around whether you should join Paul's duct to his donor duct. And that comes down to whether Paul's duct is really diseased and affected by PSC or not, and whether you should do a Roux-en-Y and anastomosis to bring the bowel up. Immunosuppression, generally most units will give 3 immunosuppressants initially and then stop steroids after the 3 months. And often people give aspirin, particularly because patients with PSC are slightly more prothrombotic in that post-operative period. So they're kind of key aspects in that early post-transplant period that we think about. We also know that the patients with what we call autoimmune liver diseases, so it's now primary biliary cholangitis, or a slightly older slide, primary sclerosing cholangitis and autoimmune hepatitis have slightly higher risk of rejection. And that shouldn't worry people. What you can see here is about a third of people get rejection. Okay, and people with PBC, PSC, and AIH get 40% of them get rejection. Actually, that's very easily treated. We don't tend to worry about it in the early phase, and as long as we get it treated nice and early and get tacrolimus levels right, and it's well controlled. But what we do is we're more careful about running our tacrolimus levels a bit higher in patients with PSC after transplant than perhaps some other indications such as alcohol or non-alcoholic fatty liver disease, and that's the reason for it. Longer term, when we think about rejection, the reason I put up this picture of the man walking a tightrope between the Twin Towers is because we are walking a tightrope over the years when we're thinking about the use of immunosuppression. We worry about immunosuppression, what risks it might lead to, whether that's infection and potentially a cancer risk, but we also really worry about late acute rejection because it's a nasty condition, particularly when you get it in the context of PSC, AIH, and PBC. So it's that balance all the time, and that's why we're constantly reviewing medications in patients who've had transplants, and there's no one size fits all. It should be something that your doctor's checking every time you come along about whether it should be lowered or increased. So we move on with our made-up case. So Paul is 1 year after transplant and his colitis flares. Now, he's commenced on an agent called vedolizumab. Some of you might be aware of that. It's a specific agent that works on the gut. And despite his colectomy, he he's advised, despite his bad colitis, it remains problematic, and the colorectal surgeons plan a colectomy. Now, Paul would like a pouch. And we get asked this often in patients with PSC, pre-transplant, after transplant. And I just want to talk through a little bit why give the advice we do. So pouches, as you can see here, this is a kind of cartoon of a J pouch, were created so patients wouldn't have ileostomies. And of course, there are good quality of life reasons for that. And about 30% of patients who have a colectomy might opt for a pouch, and that's stayed the same. And generally, people have pretty good outcomes, but it's different for patients with PSC, and I'll explain why. So firstly, patients with PSC seem to get pouchitis. This is a very inflamed a mucosa of someone's pouch. So they get worse pouchitis, and they get problems with their pouch, okay? And also, their pouches work much less well in the post-transplant setting as well. So generally, I advise patients with PSC and IBD to avoid getting a pouch because the function's worse. It will become a lot worse after transplant. And there's another reason as well. So Palak and I published on this a little while ago, about 5 years ago. And what we showed was that you're more likely to lose your liver transplant if you've had a pouch compared to not having a pouch. And that seemed to be related to issues around recurrence of PSC and also blocking off of the artery going into the transplanted liver. So that's why I try and counsel my patients not to have pouches who look like they may be heading down the route of having a transplant. Okay, so Paul's had his colectomy. He chose to have a pouch, and then 4 years after his transplant, he starts becoming itchy and developing abnormal blood tests again. And his MRCP sadly shows PSC once again. So there are various things that we need to exclude. We don't need to really particularly worry about those. But recurrent PSC is a problem. And it wouldn't be fair of me not to talk about it when I'm talking about transplantation for PSC. So this is a kind of a broad review of a number of studies over the years. But in general, what I quote to people is a 1 in 5 or 20% risk at 5 years. Okay, and there are some risk factors associated with that. So if you're a man, you're more likely. If you're younger, when you're transplanted, you're more likely. If you've got coexistent inflammatory bowel disease, you're more likely. If you've still got your colon in, it's very rare to get recurrent PSC when you've had a colectomy and you've got an ileostomy. And then other things that might be associated with this CMV. And some people have suggested rejection, but I'm not so convinced about that. So what about, is there anything we can do to prevent recurrent PSC? As you know, we don't have any good therapies for PSC. And there have been a number of things suggested. I'm just going to go through some of these. So there's a case report around the use of vancomycin. I know that a number of you are interested around vancomycin and PSC in general. And this suggested some success, but this hasn't been proven out other than this one case report. There's been some suggestion about changing people's immune system, but that's by using allogeneic hematopoietic stem cell transplant, but that's a huge procedure to go through. And then finally, people have tried fecal transplantation, and as you'll be aware, there's a trial going on in Birmingham around fecal transplantation for patients with PSC. And obviously, if that's successful, that could be very helpful for patients with recurrent PSC. So I'm aware that that's just a rapid run through, but I think, I'd agree it's helpful sometimes just to have a few slides just to set the scene. So PSC is increasingly common indication for liver transplantation, even though it's a very rare disease. Recurrence of PSC is a problem, and we have no therapy for it. And it's that combination of inflammatory bowel disease that complicates post-transplant care. And in our clinic in Birmingham, we run the IBD service at the same time as our PSC clinic, and it's so important to work closely together to lead to better outcomes for patients. So that's the end of my presentation. I'm going to stop sharing. I'm very happy to take any questions.
Thanks, Dr. Ferguson. I'm just going to start with a very broad question. What is the percentage of PSC patients who get to the stage where they need a transplant?
I guess it's more about what's your risk over time about requiring transplantation. And that, the typical doctor's answer, that depends. So it depends when you present. So if you present early with more severe disease, then you're really pretty much certainly going to come to transplantation. If you present later, perhaps in your 60s, with really quite mild disease, then it's quite likely that you won't present for transplantation. So I think a lot depends on your risk profile, and on that certainty of time, and how your disease progresses over time.
Thank you for that. I've had a few questions on email prior to the session starting, so I'll start with those. Please can Dr. Ferguson explain how some people can get to the point of needing a transplant seemingly without having had any cholangitis attacks?
So that's a good question. We seem to see two different types of progression of PSC. So some can be very much very based on the bile ducts. So they all have stricturing and cholangitic problems and jaundice, whereas others seem to progress and that their PSC leads to a lot of scarring throughout the liver, a bit like the first case, a bit like the case I was talking about, where they have a very scarred liver and their liver that itself is not working well and they're jaundiced, but they haven't really had episodes of cholangitis. Now, why you have these different types, we don't completely understand, but that's what happens.
Okay, thanks for that. Next question. My brain fog seems to have high and lows recently. How long does this last for? And will it continue post-transplant?
So I presume by brain fog, does the question relate to encephalopathy or? Yeah. So encephalopathy is a complication of all aspects of portal hypertension related to liver disease. And portal hypertension is when a patient's got a very scarred liver, blood can't flow through it, the blood flows with the toxins to the brain and leads to confusion. And that's why you get encephalopathy and what you're describing with the brain fog. Now, that does come and go over time. That's very typical of encephalopathy and it can be treated to some extent and should be cured by liver transplantation.
Very good to know. Okay, the next one is my daughter is on the transplant list under the variant syndrome section. Is it likely she will have a significantly long wait?
So this probably brings us to how livers are allocated in the UK. I'm sure you're all aware that there's a national allocation system for donation after brain death livers. The way that works is it takes a number of recipient factors and donor factors and tries to work out the transplant benefit. And that works well for patients who have chronic liver disease and signs of chronic liver disease. Whereas if you're on the list for recurrent cholangitis, your score would be very low and you probably would never get transplanted. So that means you get put in something called the variant box. The way and that's a group of conditions, recurrent cholangitis and PSC, other rarer conditions that the computer system doesn't work for. So what the computer does, it then works out how many people are in the variant box. They say it's 5%. So if it's 5%, it will then offer 5% of organs to that group. And where you'll get, the way they decide on whether you'll be offered, and obviously it depends on your blood group and your size, but also how long you wait within that variant group. So that's how the variant offering system works.
Okay, thank you for that. The next question is a couple of questions about a living donor transplant. And I think this covers both the questions, but I'll have a look at the other question next. Why is a live donor liver transplant rarely mentioned in the UK? I mean, is that true? Is this an option? And if yes, I know it's an option, but if yes, what would the UK MELD score need to be?
So living-related transplantation hasn't taken off in the UK as much as in some other countries, partly due to the success of the current transplant program. It's been successful, particularly in adult to children, but hasn't taken off so much in adult to adult. Partly that's down to concerns about the risk to the person donating part of their liver. But yes, it's an option, but not in all centres. Actually, at the moment, very few centres are offering adult to adult. And to access it, you have to be accepted onto the standard list first, and then you can potentially be offered it. It's much more commonly done in countries where perhaps the transplantation from someone who's died is not culturally acceptable. So that's like South Korea. There are some other countries where they don't have organ donation set up like we do have here, like India. So they do a huge number of living related. But yeah, no, it's not taken off. But I know that NHSBT are very keen to try and push that, and they're investing heavily into that. So I think it hopefully will start to become more commonplace over time.
Thanks for that. Question about the success rate of a transplant. What is the success rate of a transplant?
So if you take all comers who've undergone the first liver transplant, so if you about 96% at 1 year will be alive. And then if we're talking about all diseases, then at about 5 years, we're talking more sort of 80 to 85%. And PSC sits kind of in there about 82%, something like that at 5 years. Yeah.
Why do people show signs of rejection, and can stress cause rejection?
So stress, to my knowledge, doesn't cause rejection. Often people will have no real signs of rejection. It's often just seen on blood tests. As I mentioned earlier, it's very common in the early post-operative period. Often a third or 20% of patients will undergo an episode of rejection and be treated. Thereafter, it's much less common. And there's usually a reason it happens, either a change in medication, so a reduction in immunosuppression, someone forgets to take their anti-rejection drugs, or something else causes it. There's normally something that causes it late on. Yeah.
Okay. There's another question. Thank you for that. There's another question about living donor liver transplants. Do all UK transplant centres offer that?
No. So they don't, but if they don't offer it, what they would always do is, if you wanted to go down that route, they would refer you to a centre that did.
Do you know the centres, just out of interest, that do offer it?
I don't know currently. I'm not completely up to date on which do and don't, but it's never, because it's a UK system, it's NHS. It's never a problem to be referred to another centre if your centre doesn't do that. Yeah.
That's useful to know. So when you're on the transplant waiting list, are there any treatment or wellness options that can assist patients with quality of life or symptom relief?
That's a really good question. So we run a waiting list clinic, specialist waiting list clinic, for our patients, and I guess we really work on people's nutrition. It's very important. So we're working on your nutrition, trying to keep you as strong and as healthy as possible. One of my colleagues, Dr. Matthew Armstrong, who I share an office with, is currently doing a trial about exercise therapy whilst on the waiting list and the benefits of that. Obviously, it's a challenge if you're unwell and waiting for a transplant to do exercise, but there are obviously benefits. So definitely, we concentrate on nutrition, exercise. We are in Birmingham also trying to get a psychologist in as a part of our waiting list service, because we're very aware of the burden of being on the waiting list, how hard that is, spending time waiting. So we're trying to address that as well. But it may be other centres already have a psychologist.
We do know of one well, there are a few psychologists. I don't think there are many, but there are a few. There's one in Newport, and there's one in the Royal Free. And the lady at the Royal, she's a psychologist called Lucy Gorvin. She spoke at our latest information day. But I think, gosh, that is really necessary, isn't it?
No, very much so. Very much so. I think yeah, it's a really hard thing being on the list, really hard. And I think we've only picked at the surface of why. I think it's really important to give people the tools to try and help themselves. So I think the exercise, the nutrition is good because at least you feel like there's something you can do, because otherwise people feel quite powerless.
And how often do people come to their appointments on the waiting list?
So between 6 and 8 weekly. Yep.
Quite often.
Yeah, it is quite often.
Thank you for that. Again, if you're on the waiting list, are you allowed to go on holiday if you're on the transplant list, or travel, e.g. visiting relatives in different parts of the UK at New Year?
So we often get in fact, I was assessing people for transplant this afternoon, and a number asked me that exact question. So if you can, I always say to people, you can do what you want when you're on the list, but sometimes it'll have implications. Yeah. And so if you want to go to Spain on holiday, it's fine. But obviously, whilst you're in Spain, you can't be transplanted. But people have to live their lives as well. Some people wait 3 years for a liver transplant, so you can't just live in limbo. So there's a balance there. So some people choose just to go on UK holidays, and will that have implications? So generally, as long as you're not too far away from your transplant centre, it should be fine. And let your transplant coordinator know where you've gone and be contactable. But also, a number of my patients sometimes just like a break from being on the list. I have a patient who's decided to go skiing and just have a break. And I really understand that. It's just, get away from it all, that mental pressure of being on the list, waiting for a phone call, just wanting a break. So these can sometimes be very personal decisions, and just being open and sharing it with your team, I think, is helpful.
And you mentioned transplant coordinators there.
Yeah.
What's their role, if you could explain briefly?
Yeah, sure. So they're absolutely key members of a team. They are in every transplant centre. So there are 7 centres in the UK, and their role is, well, I guess they were originally set up to coordinate a liver transplant happening. Now, it's a very complicated thing. So an organ offer can come in, and a decision has to be made about whether it's going to be used. That organ then will come to a hospital. You have to then get the patient in. They have to get prepped. You can imagine you have to get the theatre ready, surgeons, anaesthetists, intensive care beds. There's a huge amount to organise. So they make all of that happen. So absolutely key. But they've often developed other roles. So here in Birmingham, they are absolutely key to the assessment programme. They're key to follow up, particularly the first 3 months, but also involved and linking with the patients. They provide psychological support. If patients have any queries, they tend to phone them. So they're really a glue of a transplant unit.
Sounds like a very important member of staff there.
Very much so.
Is the Mayo protocol for liver transplants being followed in the UK for PSC patients with early and treatable cholangiocarcinoma?
So for those who don't know, the Mayo protocol was developed a significant length of time ago around trying to provide access of liver transplantation for people with cholangiocarcinoma. And until fairly recently, if you had a cholangiocarcinoma, transplant was not an option. Now, recently, for very select patients with an isolated small cholangiocarcinoma, we are allowed to offer them a transplant, but it's very select, and we're not utilising the Mayo protocol in those patients. But so we're starting off small in the UK, which is good because it's a step forward, because previously there was nothing as far as transplantation. But yeah, we are slowly moving forward. But it's a difficult area, because it is certainly, sadly, a tumour that when I've experienced it, even when it's found incidentally in transplantation, it does seem to come back very aggressively after transplantation.
This next question, if you've been listed due to scarring of bile ducts and no interventions are viable, but you are well otherwise, could you be taken off the list?
So, I mean, you have to have clear indications, and that's fairly strict in the UK. So you have to be sick enough for IV liver disease. You have to have had enough admissions with cholangitis to hospital to go onto a waiting list. Now, sometimes people might get much, much better when we take them off. What's interesting is one of my colleagues had a look at patients who were removed from the waiting list. Now, there were people with various diseases, different liver disease that came off the waiting list because they got better. Not one patient with PSC was removed from the waiting list over that period. And then why is that? That's generally because patients have got a good reason to go on, and PSC is a progressive disease with no therapy, with medical therapy other than transplantation. And so generally, if you go on the list, you tend to stay on it with transplantation for PSC.
That answers another question on what somebody's asked as well, so I won't ask that one. This one is a kind of general question. How do you know when you're ready to be on the list? I think you talked a little bit about that in your presentation.
So by ready, do they mean like as a patient or? Not sure. Well, so it's a joint process. So I guess my role as a consultant, and I always remind people I consult, I don't tell people what to do. So my role is to first try and pick when is a good time to refer someone. And I always try and do that early, and we put them through an assessment process. And then that assessment process has a number of facets. So one, it's about checking that that patient needs the transplant, that they're fit enough for the transplant. But also we do a huge amount of education around the transplant, what it involves, what the operation involves, the anesthetic, the time on ITU, taking anti-rejection drugs, what it means afterwards. And then we'll have a meeting. We have a multidisciplinary team meeting. And we then, as a team, would potentially recommend transplantation listing to a patient. But ultimately, the decision lies with that patient because they've been through that huge educational package. And they might say, look, that's not something I want. And that's fine. But yeah, when you talk about ready, I think it's having gone through that whole process. And if at the end, your team feels that you would benefit from it, it's whether you feel ready or not to say yes.
Okay, thank you for that. At somebody's asking, our centre, we've been told that MRCP annual surveillance has stopped now that we're on the waiting list. Is that right?
So we don't do annual surveillance with MRCP. That's not something, and I imagine there's a different protocol or process in every centre. Generally, I mean, if I talk about generally people with PSC in our centre, we tend to do ultrasound. Obviously, if they have IBD, colonoscopy every year. We tend to do a FibroScan every year and an MRCP every 3 years. And the MRCP is not for screening. It's really just to see what's happening with progression of ductal disease. Sadly, MRCP in a kind of recent study really wasn't shown to be very helpful with screening for cholangiocarcinoma. So I don't think it has a role for that. So that might be why that centre's chosen to change their protocol. Yeah.
Okay, this next question is about age and if it has an impact on how long. I suspect it might be that this person is maybe younger. I don't know. It doesn't say.
Yeah.
Does age have an impact to waiting times being on the transplant waiting list?
So it's an interesting question. If one of the problems with the current system is it looks at mortality after transplantation, as you know, whilst you're on the waiting list, sorry, for a liver transplant. And there's no doubt if you're older and you have liver disease, you're more likely to die whilst you're waiting. So patients who are a bit older probably are getting, I think, with the current system, a bit of priority. But that's difficult, isn't it? Because a patient who's transplanted when they're very young will get also many, many years out of that transplant. So I think the team who run the scheme, not myself, thankfully, are looking into that in detail. But I think it's a difficult area because primarily the way the scheme has been set up is to try and reduce death on the waiting list, and it's been successful in doing that. But I do think it probably has led to less access for some patient groups.
Apologies, I just put myself on mute because my child came into the room, so I started talking. How well do PSC patients do after a second transplant for recurrent PSC?
I don't know. I don't have the survival data to mind. Again, it depends on your risks of, again, the PSC coming back. So I've seen loads of patients do incredibly well after that. And you know what's interesting, you can have a very different disease course. So you know you might get recurrent PSC quite quickly, and then that doesn't happen second time round. So there are lots of my patients who've had a second transplant, but there's no doubt it's a much higher risk procedure. That's for sure, second time round.
Thank you for that. How do I know if I have brain fog or actually have HE? Somebody asks.
That can be difficult, particularly in the early stages. So I think if people describe, a lot of patients with PSC, also PBC, describe a kind of, you know, slowness and not feeling quite right. There are tests that we can do to look for hepatic encephalopathy within the clinic, and we will do that. But it can be difficult early on to just delineate what's someone feeling not quite right or true hepatic encephalopathy. But it tends to, over time, get worse encephalopathy, and patients may develop a flap. So that's their hand-made flap. They really start, their short-term memory is really affected. They might get confused, might become very sleepy, might sleep during the day, not at night. So it does tend to become more severe. Whereas I think if it was just purely, well, not just, but if it was just feeling not quite right and not related to encephalopathy, it wouldn't tend to progress over time.
Okay, thank you. If I see my test results on the hospital portal, because we know some people do have that access, and they alarm me, for example, they mentioned cancer, is it okay to phone the secretaries to ask for a chat for clarification?
Yeah. So yes, we have a patient portal, and I think they're becoming more common across the UK. I now also write directly to all my patients and try and explain everything I can. But I guess there will always potentially be something in a letter or a blood test that might concern someone. It's very reasonable to phone a consultant secretary and request a telephone appointment. It can be difficult to make that quick just because of the volume of work that we have. But I think most consultants would try and add that onto a clinic, because it obviously would be just a quick call and often hopefully a bit of reassurance. So yes, secretary is a good point of call if you're concerned about something like that.
I think that is really good to know for people who might be concerned seeing those scan results. Somebody asks, can I have a baby after a liver transplant? Yes.
So lots and lots and lots of our ladies who've been transplanted have had bouncing babies, successful pregnancies. I also, another thing I do is look after young people who have been transplanted when they were very little, and lots of them have also had families and now got grown-up children. So generally, it's not a barrier. It just needs a bit of management. And I'd often recommend having a kind of joint session with a hepatologist and obstetrician before you plan to get pregnant. But yeah, these things are generally all hurdles that we can get over.
I mean, that's fantastic. That's fantastic. I'm sure that's fantastic for the person who asked the question. Does everybody who has a liver transplant become diabetic? Somebody asks.
Thankfully, no. But it's not a stupid question at all. So the reason that person will have asked that is the steroids and the tacrolimus are quite pro-diabetic. So particularly in that first 3 months when you're giving someone steroids, a lot of people develop a bit of diabetes, and it can just disappear away. Or if you have propensity to diabetes, it might unmask that. So it's not uncommon. Well, we don't see it much in our PSC cohort. If I think about some of our other cohorts we transplant who are more at risk, for example, our more metabolic patients, they're certainly more at risk and more developed diabetes. Yeah.
Thanks for that. What's the greatest longevity of somebody who's had a transplant? And this person said they've heard of someone having one over 30 years ago.
Yeah, I don't know what the record is. I'm sure there is a record somewhere, but I've got people often ask me, how long does a liver transplant last? So I've got lots of young people who were transplanted when they're age 1, they're now in their 30s, and they seem fine. So who knows?
Yeah.
But I always think that's quite reassuring to know.
Very reassuring, yeah. And do you know how many people are currently on the waiting list in the UK? PSC patients, I mean.
I don't know how many PSC. So currently waiting in the UK, I think it's in the 600s, I think, at the moment, something like that. Number waiting for PSC, I don't know. But certainly if people were interested, I could certainly get that data for one of the next talks, yeah.
And the person who's asked that question said they were surprised to learn that Kieran Dyer, you know, the ex-England footballer, so poorly that he was waiting 3 months in hospital for a donated liver.
Yeah, it's sad to hear. Yeah.
But he looks so, I mean, we've seen pictures of him and posted on our Facebook page, and he looks so much better.
That's really good.
Really, really nice to see. As vancomycin, you mentioned that in your presentation, be tried with any success on more advanced PSC patients who are listed?
Not really hugely successfully. Yeah, we tend not, we certainly haven't moved to using vancomycin in PSC. Sometimes we might use vancomycin in the context of inflammatory bowel disease with PSC as a kind of controlling agent while we move on to another agent. But yeah, sadly, it hasn't really shown much success like a number of other agents. Yeah.
And this person is in the States. So I don't know if transplant centres operate similarly to the UK, but generally, what should one look for when they are listed with a particular transplant centre? Apparently, you can switch. You can switch in the States. Can you switch in the UK? I would ask you that question. We just went with the closest hospital to our home, they said. And is this something that we should, you know, shop around, look around? Is there anything to look out for in transplant?
Yeah, so I guess I can't really answer for the States. It's a very different healthcare system. Transplant centres will all be very different. Yeah, I mean, as there are 7 centres, they are different. You know, some are much bigger than others in the UK, but I would say that they're all excellent. They all provide an excellent service. What's interesting is if you look at the survival at 1 year, they're all pretty much the same. You know, and have excellent outcomes, and we all work very closely together. So often, I must admit, most people go to the place that's closest to them because obviously travel, etc. You always have the right to go wherever you want. That is a right. You know, if you want to go somewhere else and be referred somewhere else, that's fine. But generally, most people will stay to a centre that's closer geographically to them, and I think that's very reasonable. Yeah.
Yeah, I mean that sounds sensible. My contact lenses are playing up, so I'm having difficulty reading the questions, but I will see if I can read this next question. Can people go into remission with PSC if they have gotten to the point of being listed in your experience? I think you've mentioned that previously, that nobody.
Nobody was removed from the list, certainly in our experience, yeah.
Okay, this is just a general question. It's not particularly related to transplantation. But if you have a bile duct infection, how long should the antibiotics take to kick in?
So it depends. So sometimes bile cholangitis can be managed with some oral antibiotics at home, and you can maybe feel better as quickly as a day. Drink plenty of liquids. However, if you're really not feeling better with oral antibiotics, and and you're getting worse or stuck, then you'll need to go into your local hospital for intravenous antibiotics. Yeah.
Thank you for that. This question about living donor again. What's the success rate of a sibling being a donor?
So I guess there are advantages to that, But as far as success rate, I'm not perhaps sure what they're asking. I mean, I guess the first thing to say is it's a big operation for someone to go through. So that's the person donating part of their liver. It's not like donating a kidney. It's a big operation and you have to go through, and, you know, not without risk. Then as far as success for the recipient, generally that's very good. Yeah, I mean, this, you know, it's a very controlled setting. It can be done during daytime. There's no kind of waiting round. So yeah, it can be a very successful procedure. Yeah.
That's reassuring. Another general question on PSC. With me having PSC, is there a test that can be done to test my children for PSC? Obviously, people are very concerned that they have passed on the disease to their children.
Sure. I mean, there isn't a kind of blood test or something like that. A lot of people will ask about risk to their children, and I very much understand that. But it's not one of these conditions that's a genetic condition that gets passed down definitely to your children, or there's a 1 in 4 risk. There certainly is a propensity in some families. You'll often find an uncle who has inflammatory bowel disease, or an aunt who had Crohn's disease, or it's more that how it runs in families. So I would say to people, you know, not to worry about it, and yeah, let them just get on.
And this poster says, silly question, but no questions are silly, so I shouldn't even read that bit out. But what's the difference between a hepatologist and a transplant hepatologist? So you're right. They always thought that a transplant hepatologist was the actual surgeon.
Yeah. So no, I'm not a surgeon. So yeah, so hepatologist just means someone who looks after liver disease. And I guess if there's transplant there, that means that you work people up for transplant and you look after people who've had after they've had their transplant as well, and manage anti-rejection drugs, et cetera, et cetera.
Thank you for that. And another general question: how far do you think we are from finding an effective treatment for PSC?
I do feel more positive than I felt for a long time, partly because there are so many studies ongoing into lots and lots of different potential areas. We have lots of agents being tested, and surely one of those is going to come up with something. Because for a long time, it was, you know, one drug and maybe, you know, or kind of son of a drug that hadn't been that successful. So I feel more positive than I have done in a long time. Yeah.
Okay, I think that is the general feeling.
Yeah, I mean, surely one of these has got to come off. There's so many being looked into, and I also think there's a real focus in from the pharmaceutical industry, which is important, into rare diseases, which there never was before.
Very good. Question about I suppose the advantages from a live liver donation versus a deceased donor. So is there an advantage to a partial liver donation, i.e. a live donor, versus a full liver donation from a deceased donor? Is there advantages either way?
So I guess it's worth considering about how that's all happened. Obviously, the disadvantages of someone who has died is that organ is taken out of them and then have to be either preserved within ice or put on one of our machine perfusion devices. It's less controlled. It might be during the night. The surgeon might be doing it during the night, the anaesthetist during the night. So, but it's a whole liver. It's an easier operation. There's not a cut surface. So I think what I would be saying is, if you're going to have living-related transplant, there are definite advantages for it, but you want it to be being done by a team that does it regularly. Because there's no doubt, you know, it's an operation that's difficult for the person who's being donated, and it's difficult, you know, putting the thing in. So it's key that that's done by someone who really knows what they're doing.
And how would you find that out? How would you find that?
I think a lot comes down to how many they're doing. Yeah, I mean, as in most things in life, if you do a lot of something, you get good at it.
And you can find that data.
Yeah, you can just ask your team. Yeah.
Okay, great. Do you know the question here from somebody asking, do any liver transplants take place in Northern Ireland?
So no, there is a transplant centre in Dublin, but no, Northern Ireland doesn't have its own transplant centre. No. They refer across to England for their transplant. So, and there's not a liver transplant centre in Wales either. There is one in Scotland, in Edinburgh.
And people in Wales, South Wales, go to Birmingham, and is that right? Normally?
Yeah. For example, I do an outreach clinic in Newport. Yeah. Have my 3-monthly trip down to Wales.
My neck of the woods.
Yeah.
A kind of more general PSC question here. Why do our scan results sometimes mention strictures where the bile ducts are narrow and then dilatation where they get wider? What is happening in our bile ducts?
So in PSC, your immune system is attacking the bile duct, and the bile duct narrows down in a section where it's attacked. So it gets inflamed initially and then scars down. But what our bile ducts do, and they're a little bit like balloons. So if you think about if you're pushing fluid down and then you led to a narrowing, the duct balloons up behind that narrowing because of pressure. And then there might be another narrowing above it, and then it balloons up behind that. And that's what we describe as ballooning. Because the bile ducts in general, so if you cause an obstruction in them, like a stone, they will get much bigger above. So I think that's what's happening when we describe beading.
Thank you. All the other questions are general PSC questions, if you don't mind taking those.
No, that's fine, yeah.
Do I always have to go to A&E if I suspect a bile duct infection?
No, I mean, as I mentioned, sometimes that can be managed at home with oral antibiotics and drinking plenty of fluid. So I often give my patients a pack of antibiotics to have at home just in case. Yeah.
That's always useful, isn't it? This question, how is the UK MELD score calculated? And if a patient is suffering from frequent cholangitis attacks, would this secure a place on the liver transplant list? I think you've answered that as yes.
Yeah.
But the UK MELD score, how is that calculated?
So the UKELD score is a scoring system that was developed. I guess it's probably worth going backwards even more. So there was something called the MELD score, and that was developed in America initially to help with just making decisions about who should have something called a TIPS procedure, which is a procedure where you put a stent through the liver. And then eventually it was used around predicting outcomes for people with liver disease. And it uses parameters such as your clotting, your bilirubin, your creatinine, to try and prognosticate about what's going to happen to you. And in America, they still use MELD a lot. In the UK, we had to have our own one, didn't we? So we called it UKELD. And added in sodium, basically. Okay, yeah. But then in America, they've now got MELD sodium. So yeah, there's lots of scoring systems.
This one mentions the UKELD score. Does frequent cholangitis attacks override the UKELD score in getting listed?
So what we sometimes will have a situation where someone's got bad liver disease that they might have a high UKELD, as that person's describing, and they've got recurrent cholangitis attacks. So they could either go in the variant or go in the classic thing. And what we will often ask NHSBT is, what's the best thing for them? So their computer model will work out what's the highest likelihood of them getting an offer, and we'll put them in the appropriate area. And that's different for different people. Depends on your blood group, how big you are, all sorts. Yeah.
Okay, thank you for that. And when is a stent considered in PSC?
So that's often around well, so I guess what we're talking about here is the use of a dominant stricture, to how we monitor a dominant stricture. So that's a stricture, a particular narrowing in PSC that worries the clinician, and we'll often assess that to see whether it's is a worrying lesion at all, often within ERCP. And sometimes people will put in a short-term stent, but it has to be short-term.
I think, Dr. Ferguson, that probably should conclude our session this evening. There's some other questions, but I think they have been covered in the session. And I just wanted to thank you ever so much for joining us this evening and answering, I think, 35 questions.
Okay. No problem at all. Pleasure.
That's incredible. And I hope that's answered, you know, the people that are on the calls questions. And yes, so thank you ever so much for that, for joining us tonight. We haven't actually planned specifically our 2024 Ask the Expert sessions, but we have started asking experts to speak. So when we get the date for our January session, we will advertise that. But thank you so much, Dr. Ferguson. Your children and your wife can now come downstairs and use your living room. But thanks so much again.
An absolute pleasure. Really nice to see you, and thank you for your time this evening. Okay, bye-bye.
Thank you. Bye-bye.